Tell us a little bit about the scope of your work and your practice.
Yeah, it's great to be here today with you at the Academy of Ophthalmology 2017 meeting. And I really presented two major topics at the Academy this year. One was focused on diabetic macular edema, and one was focused on wet macular degeneration. Both of them looking at sort of new approaches to managing a disease for which, fortunately, we have very good treatments for today, but there's always ways to improve. So, for example, in the diabetic macular edema trial I was involved with, it was a small phase 1-2 trial involving 20 patients looking at suprachoroidal delivery of a preservative-free triamcinolone acetonide preparation called CLSTA. Right. The objective of the study was to use a microneedle developed by Clearside Biomedical to inject CLSTA into the suprachoroidal space and look at the efficacy and safety in a population of patients with DME. Now, half the patients had treatment-naive DME, and the other half had previously treated DME, really recalcitrant DME. And those eyes, in some ways, were maybe particularly interesting because they had had a lot of previous treatment. They had had a mean of 23 previous intravitreal injections, anti-VEGF and steroid injections. And so the question was, can you do better with a suprachoroidal steroid delivery device in those patients? So the previously treated patients received only suprachoroidal steroid at baseline, and then beginning at month 2 were eligible for retreatment as needed through a 6-month endpoint. The treatment-naive population received both suprachoroidal steroid and intravitreal aflibercept at baseline, and then beginning at month 2, identical to the previously treated arm, received PRN suprachoroidal steroid retreatment. So the primary endpoint was at 6 months. And we had very good patient retention. 1 patient out of 20 discontinued the trial at 4 months. And what we saw anatomically and visually was that all patients had a benefit with the suprachoroidal steroid delivery. So to go through that in a little more detail, from a visual perspective, on average, including all patients, just over 5 letters were gained through the 6-month endpoint. Now, those visual gains appeared to be driven by the treatment-naive population, which gained 8.5 letters on average, compared to 1.1 letters in the previously treated arm. From an anatomic perspective, again, thinking about all patients first, there was approximately 100 micron improvement from the beginning to the end, and at the end they were approximately 345 microns. Further, from an anatomic perspective, the anatomic trajectories between the arms were similar, and at the 6-month endpoint, 89% of patients had achieved a greater than 50% reduction in their diabetic macular edema. Now, of course, in any trial, efficacy is often half the story and the other half is safety. So from a safety perspective, first of all, we think of the side effects that are anticipated with steroids. So intraocular pressure was something we looked closely at. Mean intraocular pressure through 6 months was relatively stable. There was a slight increase at months 4 and 5. And during the trial, 15% of patients were started on topical IOP-lowering medications, and 10% of patients experienced an IOP rise of greater than 10 millimeters of mercury during the trial, both of those patients in the previously treated arm. Otherwise, from a safety perspective, there were no serious ocular or systemic adverse events and no other unexpected signals.
There were no intraocular infections?
No infections within the trial, no. On average, there were 3 treatments across the 6-month trial with suprachoroidal steroid, so they were remarkably well tolerated with a low incidence of IOP elevation.
What are the implications for clinical practice?
Yeah, from this DME trial, I think it indicates that there is value to suprachoroidal delivery of steroids in this population. We certainly need to understand this better in a much larger population of patients. Unfortunately, that trial is ongoing. So there's multiple phase 3 and phase 2 ongoing trial programs looking at suprachoroidal steroid delivery with the Clearside Biomedical device. There's a phase 3 trial in uveitis, there's a phase 3 trial in retinal venous occlusive disease, and there's a large phase 2 trial in diabetic macular edema. So all 3 of those trials will inform both the safety and efficacy for retinal diseases.
In terms of optimal time for intervention, for either triamcinolone or anti-VEGF agents, what are the recommendations currently?
Yeah, I think the majority of data points towards earlier intervention leads to better outcomes, both anatomically and visually. And then we need more data on this last point, but I do think as we treat earlier and as the paradigm for management continues to shift to earlier dosing, I think we'll see that those patients often need less long-term dosing. It's a reality that we've seen in wet AMD before, where the smaller lesions often require less frequent dosing on average. There are certainly exceptions to that. So we don't have that data conclusively yet, but there are many ongoing trials, and the ones that I think that are most relevant to this question include the DRCRNet Protocol V, which is looking at DME at an earlier stage, so it's center-involved DME without substantial visual acuity loss. And that trial is randomizing patients to intravitreal anti-VEGF dosing with aflibercept, observation, or macular laser at baseline. And we'll see if there's a benefit to earlier intervention in those eyes. The other approach to early intervention, which I think is a fundamentally important question that's being asked, is being asked by the Panorama and the DRCRW trials. And both of those trials are looking at anti-VEGF dosing compared to standard of care, which is observation, in what would be considered a high-risk NPDR state, so non-proliferative disease, so no neovascularization, and really no significant DME. Can you change the trajectory of this disease by early intervention?
What are the correlations between disease acuity and hemoglobin A1C?
Yeah, I sort of have two answers to that, and I believe that we as ophthalmologists need to always remember, and I think we as a society are united in this front, and that we are doctors and we are comprehensive physicians for what that means in many regards. And so it's really important that we consider our patients' systemic well-being as we manage them. So it's critical that we talk about blood pressure, blood sugar, cholesterol, all those issues with our patients. I think that we're unified in that. The fascinating corollary to that is that whenever that has been looked at, especially in large phase 3 trials, is that there is a remarkable lack of correlation between A1C control and responsiveness to anti-VEGF therapy. So what that means is it's not saying that control is not important. Control is the goal. But it is also saying that just because someone's not well controlled and their A1C may be higher than they and we as physicians would like, they can still have a very good anatomic and functional response to intravitreal anti-VEGF therapy.
Okay. So what are your future directions with this particular line of research?
Yeah. You know, I think first and foremost it's important for patients especially to realize that there are very good treatments for diabetic macular edema, diabetic retinopathy, and wet age-related macular degeneration. But that said, I'm a firm believer that the field can and will continue to move forward. And there are many ways that we can move forward together. So one of them is a treatment burden issue. You know, it's a lot for patients to come in for monthly dosing or every other month dosing or even every 3-month dosing. And so I think the field needs to find more durable treatment options. And I think that there are a lot of avenues to get there, and I'm excited by many of those paths forward. The other, exciting line of movement forward is improving outcomes. So if you look at DME and wet AMD treatments over time, while highly effective, there is a substantial proportion of patients that will never get back to the level of visual acuity that we as a field and certainly they as patients want to achieve. Right? We can do better visually also. I think to get down the path for both of those approaches, we need to think about new targets for drug delivery, such as suprachoroidal delivery, and then maybe most importantly, new targets beyond VEGF as a target. And there's a lot of excitement in, for example, the angiopoietin-2 pathway, the TIE2 pathway. There are 2 major companies now addressing a blockade of angiopoietin-2 with 5 ongoing phase 2 trials spanning DME and wet AMD. And then there's a separate company looking at more of a systemic delivery to the TIE2 pathway axis modification, really in the setting of diabetic retinopathy.
Is there anything else that you'd like to share with us about your work that you're particularly excited about?
We focused a lot in this discussion on DME, and I think that AMD is a lot of excitement also. So at this Congress, I also presented work on, I presented the completed data set from a phase 2 trial called Capella, And just to briefly summarize that, because I think it's relevant, especially to patients as we move this field forward. So Capella looked at the addition of blockade of PDGF, platelet-derived growth factor receptor signaling, in addition to VEGF-A blockade. And the Capella was a very well-organized phase 2 trial, 500 patients who were randomized to 2 arms of combination dose therapy compared to VEGF-A monotherapy blockade with aflibercept. And, the take-home message was that there was no additional benefit, either visually or anatomic, with combination dosing over VEGF-A monotherapy. And I think that the take-home from that for me is just emphasizing the fact that VEGF-A monotherapy, by blocking that growth factor, we have had remarkable success over the last 10 years. The bar has been set remarkably high to improve our outcomes, which is great from a patient perspective. VEGF blockade for wet AMD management, patients can do very well when they're treated appropriately. That said, I am a firm believer, like I said, that the field is and can move forward and will move forward, and we're in the process of doing that. But PDGF has proven now in 2 large trials to be a target that does not add value to wet AMD management.
Out of all the work that's coming, that you've conducted, and the pipeline, what should patients expect in the next 5 years?
Yeah. I think on the 5-year horizon, VEGF-A blockade monotherapy is certainly here to stay. It works exceptionally well. It's been proven repeatedly in multiple prospective trials to be exceptionally effective. That said, not everyone improves, and it's a significant treatment burden, and both of those issues are being addressed with multiple ongoing phase 2 programs. So before we can change practice patterns, we need data from phase 2 that is then translated into phase 3. I think on the shortest time horizon, there is likely going to be at least 1 and maybe 2 other anti-VEGF-A monotherapy pharmaceuticals that may get commercially released. And that may change the durability question. It may change the durability and how frequent some patients are dosed, although I think that data needs to be explored further before the true clinical impact of that is realized.
Professor, thank you so much. This has been an extraordinarily illuminating and very insightful conversation.
Thank you.
Thank you.